Good afternoon, everybody. My name is Megan Butler, and I'm a part of the Liftoff PGH team. And it is my pleasure to welcome you to today's session, Cultural Competency in Healthcare Education, led by Dr. Abdussalam Sudi and Dr. Judy Chang. So today's conversation should be a really interesting presentation. With revised education models, workplaces and institutions can bring physicians into the multicultural conversation and help clinicians at all career stages to better serve patients and ensure the brightest future for our region. So today's conversation is going to be focused on making sure that physicians and other healthcare providers in our region are better prepared to offer culturally and linguistically competent care. So with that, I'm going to pass off today's session to Dr. Sudi and Dr. Chang.
Well, thank you so much, Megan. It's a pleasure to be here. We would like to really express our gratitude to Liftoff Pittsburgh for this partnership and also for making space for this, as you said, very important conversation that's going to be adding a lot to the part of the conversation in the conversation. I would also thank my colleague, Dr. Chang, Judy Chang, for participating in this as well. And so this is going to be our outline. Today, we will work through the meaning and value of cultural competency, why we need it in our lives, and how to best approach it. And we will also illustrate with various examples from our work that pertain to cross-cultural communication. So what is cultural competency? And please feel free to supply your responses as well as we go. So we'll be asking questions throughout the presentation. So cultural competency is the ability to function effectively in cross-cultural and cross-linguistic environment. It can be thought of as a chart for perceiving and interacting with the world around us. It's about being flexible, reflective, and accommodating. It's about appreciating differences and creating safe spaces to learn about others. It is about improving empathy and understanding in the workplace and beyond. It's about collaboration, teamwork, critical thinking, and diversity. And most importantly, also, it is about engaging others rather than just accepting them. And for the past year, this has formed a big part of a project that we have been working on titled the Cultural Engagement Playbook. The scope of cultural competency is broad, but these are some principles and premises to keep in mind. We belong to several cultures at once, and they're not static. If you even think of something like our own identity, as individuals who operate along several social frames. I am here today as a co-presenter, as a collaborator. I am also a father, I'm a husband, I'm a teacher, I'm an educator. So we are different people. So parts of our identities are emergent in context based on where we are and who we are talking to. Culture is expressed through individuals, not stereotypes. So we have to give people a chance to tell us who they are in those specific situations rather than boxing them in blindly in categories. So the goal is to understand individuals in their cultural context. Every human encounter is a cross-cultural one to some extent. So I could be having a conversation with my own brother, we grew up together, and that could be cross-cultural because we have different experiences and different educational backgrounds and a number of other things that come into play. Encounter might also have different needs in that particular conversation. My brother could be my doctor, for example. So cultural competency is important in every aspect of our lives and has a big relevance in healthcare, as we will show you today. An individual's culture is made up of multiple different factors, as can be seen here. In any given situation or decision, it may be impossible to isolate the driving factor, something that might be driving a person's behavior or a person's style. So even if we were to put this culture under a microscope, under a conversation analysis microscope, it might be really hard to know exactly what's driving a person's behavior. Is it age? Is it gender? Is it the language? Is it literacy? Is it experience? Is it religion? So these things are very interrelated. So these factors, or to be precise, cultural variables, work together sometimes, and it's very hard to isolate which one is driving a person's behavior. Culture has long been compared to an iceberg. Deep inside lie our core values, family narrative, identity, and more. And this has also been articulated very well in Le Petit Prince. I don't know if some of you read that, The Little Prince, where it says, l'essentiel est invisible aux yeux. What is essential is invisible to the eyes. And again, this is part of the difficulty working cross-culturally and cross-linguistically speaking. Going off the fact that diversity means different things to different people, in 2017, I invited students, faculty, and staff to the University of Pittsburgh studio to discuss what diversity means to them. I embedded 3 questions in my casual conversation with them. What does diversity mean to you? What is the value of diversity in your life and work? And how can we achieve it? Following the murder of George Floyd and the current pandemic, I have taken these questions off campus and into the community virtually. Doing this work has shown me clearly that cultural competency continues to be a work in progress, as the value people assign to diversity varies greatly depending on their definition. And please, participants, feel free to share in the chat box what diversity or cultural diversity means to you and the value of it in your life and work, and also your opinions about how we can achieve it. So there are several arguments why we need to address cultural competency. A simple one is ongoing shift in demographics. According to the American Community Survey, over 55 million respondents spoke a language other than English in the home. And that's a 140% increase from a similar survey in 1980. 45% reported some degree of limited English proficiency. That's about 11.5% of the total US population. You can also think of it as about 1 in 7 Americans do not speak English as their first language. And these are some local numbers from Pittsburgh and Allegheny County. 5.8% are foreign-born county residents, 8.3% are foreign-born city residents, 48%, that's a 48% increase since 2000, and it is expected to continue. Asian, Latino, and African communities have grown by 50%. And in Pittsburgh, we have welcomed about 4,000 direct refugees placement from 33 distinct countries. This information comes from the Allegheny County Department of Human Services, dated 2015. Another argument why we need to address this is a legal one. Federal laws require that service providers, so if you are a hospital or a clinic that receives any form of federal funding, you are required by law to meaningfully accommodate people with limited English proficiency. And I underline meaningfully. As a linguist, I'm aware that there is over 100 languages spoken just in the state of Pennsylvania. So to expect having in-person translators and interpreters or language brokers all the time might be hard, but we can definitely in the discussion explore possibilities of making that happen. This is also part of the Executive Order 13166, which led to Public Law 101-52, 1994, which led then to the creation of Office of Minority Health, which was charged with developing what's called class standards, and that's culturally and linguistically appropriate services, which consist of 15 principles. A general one, make sure that we provide effective, equitable, understandable, and respective quality care. And it also consists of these 3 interrelated themes about governance, leadership, and workforce, communication, language assistance, engagement, continuous improvement, and accountability. But let's remember that checking a legal box to provide language accommodation is not enough. The job of interpreters and dynamics of working with interpreters can be hard. Again, participants, if you have had any experiences that you'd like to share, please feel free to do so in the chat box. Against the claim or general assumption that doctors hold more power in an interpreter-mediated medical interview, interpreters function as interaction managers, bridging a disconnect between patients and their physicians, and thus hold more power. I don't know if Dr. Cheng will agree with that. Interpreters speak the language of the doctor or the healthcare provider, and they also speak the language of the patient. So in a way, they are able to control information and topical development as well of the medical interview. We should keep in mind that even in idealized production format, question answer, interpreted medical interview takes longer than same language visit. And this is something to keep in mind when we are budgeting our time seeing patients who are limited English proficiency. This is a simple exchange. How are you? It has to go through the interpreter back to the patient. I'm doing fine. They tell doctor I'm doing fine. Great. Just that takes twice as long. But production formats in interpreter-mediated medical interviews are not always ideal. We have possibilities like Exchange B, where you have these side conversations. Can you ask the patient how they are doing? And then you have a side conversation back and forth, back and forth, back and forth. And the healthcare provider is left out. Exchange C is possible, where we observed conversations happening between interpreters and doctors, and the patient is uninvited, left outside of the interaction. This was a study that used conversation analysis, videotaped interviews, same language visit, and compared them to interpreter-mediated visit. So if you look at the first part, from same language visit, there were 55 questions from the healthcare provider. And so answers were 53, and only 2 were not answered. And that's amazing, I think. I don't know if Dr. Chang agrees as well. I think that's pretty good that only 2 were not answered by the provider. However, in interpreter-mediated visits, the number of questions is 33, which is alarming, by the way. The number 33 questions is much less than 55 questions. I don't know if it has to do with the time being reduced, but not past the provider were 18 questions, no answers for. So 22 questions were completely lost. This comes from another study by Arangori and colleagues. And so if you look at the chart above the diagram, the first one, the top one, there's sort of a typo in the original publication. So that patient should be 25% and physician 25%, and interpreter talks about 50%. And again, that's idealized, right? Because it also depends on the language at play. I speak Arabic, and Arabic is a very verbose language. So sometimes one sentence in English might require 3 sentences in Arabic to fully capture the meaning. But again, that's idealized. So when these interviews were actually timed and subjected to conversation analysis, the findings were interpreters spoke actually 27% of the time, patients spoke 24%, and physicians 49%. So likely then, one of the conclusions we can draw from here is that interpreters were summarizing, were not passing maybe certain answers to the provider, and were deleting perhaps information. So while we are rightfully concerned about the burden placed to come up with the right equivalent, sometimes it's hard to come up with something equivalent in the target language, or to mediate conversation to align with pragmatic filters of the target and source languages. We also need to worry about what we are asking interpreters to do, right? Are we asking them to deliver negative news? And this is something that's usually not accounted for in most of the studies that we have looked at. Are we asking interpreters to pass complaints? Most of the time, depending on the relationship between interpreters and patients, interpreters become very hesitant to transport delicate matter information. We also need to keep in mind that the job of an interpreter, the job of the provider, and also the patient is hard when you're working in interpreter-mediated conversations, as I said earlier. Social factors affect our health, where we live, learn, grow, and work. They matter more than the quality or type of medical care that we receive. So there are those differences in health that are natural, and to a certain degree, they are acceptable because we have no control over them. But there are also differences in health due to our socioeconomics, education, literacy, and the environment where we live and grow. And they are preventable and are therefore unfair and must be eliminated. Based on information from the American Medical Hospital Association, about 1.7 million individuals experience homelessness. 3.6 million people can't access medical care due to lack of transportation. So they might have access to healthcare, but they have no transportation to take them to the hospital to be seen. 40 million people face hunger, and 11.8% of households in the United States are food insecure. Sorry, I missed it. And this is a detailed summary of the various components that fall under the category of social determinants of health and their impacts on health outcomes, such as mortality, life expectancy, and functional limitations. And of course, they include some of the areas we have talked about now, like cultural and linguistic competency, language literacy, and education, as well as economic stability. Physical environment, social determinants, and behavioral factors drive 80% of health and matter more, as mentioned earlier, than healthcare. So going to the doctor, having insurance to go to the doctor, has a very small percentage in the overall health of an individual. Place and zip code matter. Sometimes few miles, a mile or two, can make a huge difference in life expectancy. Sometimes it's a 20 years difference. And so we need to keep that in mind as well. Food matters. And if you look at some of the scary numbers, even in Pittsburgh, 21.4% are food insecure, and in Allegheny County, 14%. And that's very concerning. We can't talk about social determinants of health and not address them in the context of COVID-19 as well. Low-income housing and shelters can't provide social distancing as we are experiencing and we have experienced since March. Social distancing is a privilege. I'm very grateful and happy that I live in a townhouse that has a driveway and a backyard where I was able to take my children out. But there are lots of families who lived in crowded apartments and crowded housing. Lots of people couldn't afford to pay rent because they lost their income. Lots of people became food insecure. Language access, as we talked about earlier, is also important. Many people, many limited English proficiency population in Pittsburgh, there were times when they called me, is it okay to go out today? Because we were not sure what the governor was saying. They were confused about quarantine, isolation, shelter in place. Those terms are very technical that people had really faced difficulties understanding and making decisions about their next moves. And then social isolation. Some of us have high-speed internet, so we're able to log into Zoom and connect with our families and friends, but lots of people did not have that kind of access. I release the conversation floor to my colleague, Dr. Chang. Thank you.
Thank you, Dr. Sudi, for making such a compelling argument for the importance of cultural competency in healthcare. And then this essentially is where we want to transition a little bit to bring us to the question of how do we actually have cultural competent, culturally respectful conversations in healthcare? Both Dr. Sudi and I have focused our research on patient-provider communication, and it's been exciting also to collaborate with each other and learn from each other's expertise. You know, for me as a healthcare provider, I've benefited from having the expertise of someone who's so well-versed in linguistics and humanities to really sort of inform the work that we do. From this work, we then have been able to identify skills and approaches that then we're translating into teaching healthcare students, medical students, trainees, how to improve their communication with patients. And so I just wanted to share some of these examples with you now. Next slide.
Yes.
So one of the studies that was funded by the Agency for Healthcare Research and Quality was looking at a particularly vulnerable group in a particularly sensitive topic. And so this study sought to understand how healthcare providers can best ask and talk about intimate partner violence with their female patients. At the time that the study was commissioned, although multiple medical organizations advocated that healthcare providers should be asking all of their female patients, all their adult female patients about intimate partner violence, there was little guidance on how these conversations should actually occur. And so our study used focus groups with women who experience intimate partner violence to learn how they would advise healthcare professionals to have these conversations. Next slide, please. And so a key component that I wanted to point out was that the design of the study, which was to focus on the voices and perspectives of the women themselves, was crucial to understanding the context and culture related to their experiences. This approach allowed us to address that doctor-patient asymmetry that oftentimes occurs in these visits, and essentially is illustrated by this conversation. And so, as you can see here, the doctor is actually asking a question to try to explore intimate partner violence. However, in the patient's response, you can see that her interpretation is regarding neighborhood safety. Next slide, please. In terms of some of the findings and themes that arose from this particular focus group study, we saw that there were three main things. One was to give a reason for asking, which was that women wanted to have a sense of why we were asking in order to reduce the stigma around this sensitive topic. So as this quote, oops, if you can go back to the other one, as this quote illustrated, if the doctor prefaced it with part of my routine is to ask this of everybody, then you don't feel singled out. A second theme was ensuring a safe, non-judgmental, and supportive environment. And as this particular participant indicated, that support can be really impactful with regard to their sense of comfort, but also sense of self. As this woman described, just with a simple caring word, you feel that you are really worthwhile, that they care about you, about your situation. And then the third theme was to actually provide information and resources about intimate partner violence, regardless of disclosure. The women explained that disclosure can sometimes be hard, but that they would still find the information, resources, and supports useful, even though they weren't ready to disclose. As this one woman described, they can say, well, look, ma'am, well, if it hasn't happened to you, that's good. But just in case it does happen to you, here's the information. These themes have become crucial and center points to how we are now guiding some of our training in terms of teaching medical students and other professionals how to address intimate partner violence. It's certainly a component of the trainings that I do with medical students, and it has also helped to be some of the, or inform the universal counseling and universal resources approach that the Futures Without Violence, a national advocacy organization, has been using in trying to promote to other healthcare providers. Next slide.
So the presence of the computer makes certain conversations, including those about sensitive topics such as domestic abuse, very difficult. But computers now, as you could see in this, in the exam rooms. So we need to know then how the information that Dr. Chang has described is inputted into the system, and how technology, machine learning, and natural language processing account for cultural information. Additionally, we also need to consider that some patients may have distrust of information technology that might need to be addressed. So where do we go from here? Well, we can go in a million directions, right? But one thing is for sure, we need educational programs in our hospital systems and in the curriculum to address diverse aspects of cultural competency. And an example here is the MedEdu 2240, a master's level course that I could direct through the Institute for Clinical Research Education. This is a concrete example. We talk a lot about the value of humanities in health. So this is a concrete example of integrating humanities into health intervention or clinical care. It focuses on cultural and linguistic competency to demonstrate how these skills enhance our understanding of social determinants of health and working with limited English proficiency and so on and so forth. And this is a snapshot of our syllabus that was published in European Journal for Person-Centered Healthcare in 2017. These are the themes, and we have highlighted a couple of them already in the earlier part of the conversation, talking about appreciating language, linguistic competency, and also patient-centeredness, and as well as social determinants of health. An important part of the course is also the connection we make with our communities through field trips to religious center. And this image here is from a visit we did a few years ago to the Islamic Center of Pittsburgh with our fellows and residents who are signed up for the course. A chapter that came out recently in an edited volume, Diversity Across the Discipline, we highlighted an important exercise we require that our trainees think about the cross-cultural or cross-linguistic encounter and think about it, define the problem, and share what they learned from the problem and how they would teach it to others. So thanks to a grant from the Provost Office and the David Berg Center, we looked at about 70 reflection essays, and we categorized them based also to learn what kind of themes our trainees are interested in.
In addition to offering opportunities to learn about and appreciate different cultural perspectives and experiences, we also learned a bit about the key components that are necessary in order to actually educate competency. And there are two key elements that have been a part of both having cultural competent assertive interactions as well as teaching about cultural competent interactions. And these two are safety and space, making sure that we've got the time and space for reflection and for people's perspectives to be shared. Next slide. The key components in terms of like when we're trying to advocate the interactional styles and the key objectives that we're hoping to convey are demonstrating respect, making the patient feel heard and understood, and conveying caring and concern. There is a type of communication style or skills, set of skills that has been being taught across the world, actually. The Academy of Communication and Healthcare is one organization that has been using this approach to train healthcare providers in terms of patient-provider communication skills. And these are the different components that actually are the focus of that in terms of each visit. One is to set the stage, which is making sure that there's appropriate introductions and making sure that the patient is comfortable. And then beginning the visit by eliciting the patient's concerns and understanding what their agenda is and their set of priorities before the provider actually starts to mention what their priorities would be. The emphasis is on using open-ended questions, and they use an ask, tell, ask model, meaning that you would begin with open-ended questions, focusing on the patient's perspective before offering information, guidance, or counseling, and then end with that open-ended sort of approach. And then finally, one would finish the visit by confirming mutual understanding and ensuring that the patient's key agenda items had been addressed. Next slide.
Okay, another be me. So one other example is a Humanities at Work project that we have created in collaboration with Dr. Chang, Department of Obstetrics at McGee Women's Hospital, School of different departments, the School of Medicine, Department of Family Medicine included, linguistics, School of Business and Education. So we created this initiative which builds both in the Humanities and Health Initiative and the linguistic internship, which Dr. Chang plays an important role. She hosts every year few interns to analyze data, medical interviews, obstetrics visits, primary first obstetric visit, and look for different linguistic sequences, how doctors solicit concerns about intimate partner violence. So we have been collaborating with her for about 7 or 8 years now. We also place our students with the English Language Institute, with 3M, model, which is now 3M, Voce Technologies, Semantic Compactions, UPMC Enterprises, Articulab, Wicked Tongues, and Living Tongues. So these are, again, educational opportunities available to our student population as part of the Dietrich School of Arts and Sciences at the University of Pittsburgh. And this is the initiative that we started with at the beginning of this talk, Humanities and Health Initiative. So we have been holding events once a year. It's a cross-unit partnership to talk about social determinants of health, linguistic competency, and a number of other relevant topics. So cultural competency encompasses many fields. And as we have shown through examples, it is important in every aspect of our lives and has relevance in healthcare. Addressing social determinants of health is important for improving overall health, reducing health disparities, eliminating unjust health outcomes differences that are rooted in social and economic disadvantages. Broad, inclusive, and personalized approaches work because every person has unique social services and needs, and one size fits all approach does not work. Health is important in all places. I think most of the time we tend to address health in the clinic, but we really need to look at health in our neighborhoods, in our work environments, and work together to create a diverse, inclusive, and just environment for all people. And thank you very much. I would like to just make some quick acknowledgements. I'm really very grateful again to my colleagues and partners at Liftoff Pittsburgh, Megan Butler, who has been working with us for a number of months, putting a wonderful event together, and Natalie Stewart, our colleague, and Mara Left, and also our colleagues, the Humanities and Health colleagues at the University of Pittsburgh, and colleagues at the ICRE, the Institute of Research and Education, where we ran the master's level course that we have highlighted earlier, and our community partners who have been hosting our interns for diverse experiential learning opportunities, and also thankful to our interns themselves. And if there are any additional follow-up questions, we have put an email there. And we are looking forward to the exciting part of having a discussion with everyone. Thank you.
Great. Thank you so much, Dr. Sudi and Dr. Chang, for leading us in that great presentation. At this point, like Dr. Sudi said, we would like to open it up for questions from the audience. So please feel free to type your questions either in chat or in the Q&A panel specifically. Either way, we'll be able to receive those questions and share them with our panelists today. So I'll go ahead and start us off with a question. And this is actually inspired by a session we had earlier today at Liftoff PGH. We hosted a session earlier today with Kids Plus Pediatrics, who is a local pediatrics practice here in Pittsburgh. And one of the themes that they discussed in their presentation was the role of trust in a relationship between a provider and a patient, and just how fundamental that idea of trust was in the care relationship. So I wanted to pose that as a question to both of you. What role do you think trust plays in this conversation in cultural competency? And how do you think that physicians and other providers can integrate elements of trust into their care models?
Trust is essential. It's absolutely essential. And especially with regard to patient-provider interactions. it's even more important because there have been communities and individuals who have experienced harm, and therefore there may even be the need to regain trust or actually build that trust. What we've noticed in terms of some of the communication approaches, though, is that a key component of building trust is creating that safety in that space and really helping to give a platform, or at least a sort of a helping to center sort of the patient's perspectives and experiences, as well as their needs and concerns, and giving space to allow them to express their distrust, actually, to express their unhappiness, to express some of their frustrations from the past, and then create, you know, a dialogue to be able to move forward.
Yep. And I trust is pretty much everything that we have said and we didn't say. That's the whole thing. Building trust that's the best outcome you want to have and it applies everywhere. In my own classroom too, I have to work hard as well to build trust with my students. They have to know that I'm an expert. They have to know that I am here to help them. I am not their opponent. I'm your partner. And I think so. And engaging, really the key is to engage people in their care. If your patients are engaged, then they'll work with you. It's like there's a methodology called the flipped classroom, where people end up doing more work because, you sort of empower them and you give them the tools and they buy into it. And I think it's important. And one challenge that we are currently about to face is now we have a vaccine. We've worked very hard to have a vaccine. Will communities take that? Will they trust our system? And so I think, and that's where the humanities come in. It's a medical question, it's a public, but it's really largely humanities question. But building trust is privacy. People have the need to be able to trust you. Even working with limited English proficiency, if you're bringing an interpreter from the community, patients might not be as willing to come forward with information because they worry that the person you brought, they see them at the local religious center and they worry. So we have to also be very careful about the participants that we invite in our clinics. And so, but yes, it's a great question. Building trust is everything. And hopefully that's helpful. And we are happy to expand if there are any follow-up questions on that as well.
No, that's great. Thank you so much for your responses. We do have a few questions coming in via chat. So Stacy says, I appreciate your great efforts in educating health professionals on having difficult conversations with patients. How do you translate these efforts into written communications or resources that are provided to patients?
Oh, absolutely. I think that can be something that we have to think with a lot of intentionality as well, in order to make sure that what materials we're producing are appropriate and applicable to the individuals to whom they're targeted. The things that we've used before have been to try to speak in the voices of the targeted audience as much as possible. And so oftentimes, sharing sort of concerns, but then acknowledging that may not necessarily be the same concern that everyone might be having. The other component is to make sure that the language is accessible and appropriate. I think sometimes those of us in the health professions, when you're used to kind of speaking your own language with your colleagues and such like that, it is that some of these words and terms and phrases and even ways that we frame things are not what others may absorb. And so part of that is to make sure that we do that. And I think a lot of it is to actually partner with the communities and populations in the creation of these educational and resource information to make sure that they've been vetted essentially by the individuals who'd be using them.
Yeah, I think Dr. Chan covered perhaps everything that I want to add to that. I think that's engaging communities in the making is definitely an important step in making that happen. Yeah. Yeah. Thank you.
Great. We have another question from Jean Marie. Following up on Megan's question, how does trust and confidentiality play into women seeking care with children in tow or without available childcare and not able to freely answer the leading questions relative to potential domestic violence? And then there's a second part to this question. So also, if there is an interpreter involved, how does that play in? And then there's a third part to the question. So what is the success of interpreters in telehealth visits if there are 3 remote entities in that virtual visit? So feel free to address that, in any of back to certain parts.
We can collaborate, but I think I will let Dr. Chang goes first again, since the question has to do with her.
I can tackle the domestic violence component, but Sudi, perhaps we can tackle the interpretation sort of component. But certainly in terms of safety and confidentiality and privacy, I think especially with the transition from in-person visits to telemedicine, there's been a really highlighting of the issue of privacy. Because as you can see me, but you don't know who's behind the camera, right? You don't know who's sort of off to the side out of my screen. And so there is the need now for us to be really careful about how we bring up different topics and what kind of position we're putting people in, if we're framing things in perhaps as a way of like screening, if we're actually asking them a direct question to actually ask them to reveal some type of information about themselves. And that could be in the case of having, children in the room as well. Any child who speaks, who can hear and speak can then also share sort of what they listened to somebody else. And so that sort of rule of confidentiality isn't necessarily applicable to that particular child. And the same sort of thing with interpreters. Now, formal and professional interpreters are bound by confidentiality and professional guidelines. And so that's why there is a preference to actually use specifically trained and professional interpreters in our visits. But there are some times in which interpreters are more community volunteers or, personal affiliates of the patient themselves. This is one of the areas where that last theme among the 3 themes that I mentioned, I think has been even more emphasized, meaning that instead of framing things as questions, like, is this going on with you? If we actually provide it as universal counseling by saying, you know what, there's a lot of stress going on, and we hear that there's a lot of issues with regard to safety, including domestic violence, increased substance use, problems with mental health. We want to provide everybody with the resources that can address these things. So I'm going to give you these brochures, or I'm going to give you these series of numbers or websites or other links, and that's for you to use or to share. It doesn't matter if it's affecting you, but we know it's affecting a lot of people, and we're going to get it out there. And so that's one way to safely get the resources out to individuals when they may not feel comfortable disclosing it.
Yeah. Thank you. This is also, again, a great question, and thank you, Dr. Chang, for addressing a big part of it. And so what we emphasize in our teaching, cultural competence is a work in progress. So we don't teach knowledge about cultures. We talk about cultures, but really it's an approach. And it's an approach that depends on context and participants, who is involved and where, and what type of visit, and what's the topic, and what is the purpose. I think those questions are always relevant. So you're not going to walk into an exam room, I've taken a training, I am ready. I think what we emphasize in our training is have sort of that it's relativistic. There's nothing absolute, right? And so when we're thinking about interpreter, for example, or their work, we also have to think about a number of scenarios. Interpreters in obstetrics visit might not be the same as orthopedics encounters. So we have to think about the type of visit and what that visit entails. An obstetric visit does entail sensitive topics having to do with eliciting information about domestic abuse and so on and so forth. But also the multimodality aspect of it. And I think some of this stuff is also being addressed at the conference, in terms of in the context of technology with televisits and telemedicine. I think we have to keep in mind, as Dr. Chang, if you're calling somebody in the home and you're asking them about intimate partner, their partner could be in the living room, and so you could be overhearing the conversation. So they might be hesitant to be more forward. But and this also example reminds me of an example that a colleague of mine who has been teaching the course with me as well, where she was seeing a Muslim patient who came to her clinic, and the Muslim female patient brought a neighbor, a volunteer from the community for the visit. And she had to make a very good decision. Would she count this as a visit or not? counting it as a visit might not be the best thing for the patient, because she was going to ask delicate matter things, and having a male person translate that to a female Muslim, likely, as we have seen in the earlier graphs, likely that information might be deleted or not passed along to the provider. I think there was also a part that's sort of more of a human computer interface, where it's a telehealth, and you have an interpreter in one location, you have the patient in another location. I have not personally observed that. As a linguist, I would love to have my hands on that kind of data to really understand. There are challenges of bringing participants together remotely. I can think of one situation that's also multimodal, but the participants were in person. We had somebody, an aunt who needed ASL, and a mom who needed Spanish interpreting. And so an interview that was supposed to be 20 minutes ended up being an hour. And so, but again, really the point is keep in mind participants there, physician, patient, who else is there, interpreters, there, are the community volunteer, are the hospital interpreter, and the purpose of the visit. If your visit, like Dr. Chang's visits, are mostly involved delicate matter topics and sensitive topics, then we have to be mindful of who the participants are. Megan, I hope we addressed all the branches of the question. It's a great question, and it really brings a lots of important pieces together.
Yeah, no, I think you did. So great job there. And that's a really interesting conversation. I hadn't thought about the privacy implications of telemedicine, not necessarily knowing who's on the other side of the screen, but also if you're doing the telemedicine visit from your own home, do you feel like you have the privacy that you need to disclose certain information?
That's right.
I think that's a really interesting
that's right.
implication of the new virtual visits. So that's a great question and really great comments there. We have a two-part question that has come in from Brandon, who asks, what are your thoughts on utilizing a cultural ecology approach to understanding cultural overall and the culture of an individual? And then I'll read the second part of the question too. How do you teach students to address the subjective nature of culture, how culture is perceived and understood by the patient in the clinical setting?
I do know, Dr. Chang, have you used, and I have not used the cultural ecology approach in my work.
I have not, so I wouldn't be able to speak to that, but I guess it is making me think about some of your exercises that you use in your course, such as the culture box.
Oh, yeah.
That might be something to talk about.
Yeah. So the teaching, how the approach in which we deliver our cultural competency training is really about, it is very participant driven. Rather, like I said earlier, we're not bringing, again, whatever we're teaching, one, it is participant driven because we would like to align what we are doing with the reality of the clinics, but also with the reality of our demographics, but most importantly, with the reality of the trainees themselves, who they are, where they come from, their background. And I think that's important, again, because by creating a climate in the classroom where people, well, if we're trying to teach trainees to engage their patients, but we're not teaching them how to engage each other, then that's not gonna. So we have to give them an example, a concrete example. And usually at the end of the training, we get really very good feedback that, that the environment we have created has allowed them some level of disclosure that wouldn't have been possible in other environments. And Megan, please, we're gonna ask again if you don't mind reading the second part of the question as well.
Sure. So the second part of the question was, how do you teach students to address the subjective nature of culture, how culture is perceived and understood by the patient in the clinical setting?
Well, so culture is a very broad concept, as I mentioned earlier. It's and it also interacts with several cultural variables. And it's really very hard, as I mentioned earlier in my presentation, sometimes to interpret a person's behavior. I say something and Sudi says something, okay. Does it have to do with the fact that I am from Morocco? Does it have to do with the fact that I am a linguist? Does it have to do with the fact that I am a father? Does it have to do with the fact that that's just my person? So it's really, it is subjective. It is broad. But the idea is to really teach it, the method is to teach it as an approach, to teach people to be critical thinkers, to teach people to look at individuals rather than stereotypes. We're not judging people by their accent, by their language, by their physical looks, but we're actually rather creating an environment where we are allowing them a chance to tell us who they are, right? And so that's, so it is, so in that regard, you know, saying it again, it is really a work in progress. And again, even if we're doing the same exercise I did with diversity and asking people what culture means to them, we're gonna elicit a variety of responses. If we were to ask them again how they value culture in their work environment, their responses again will depend really on how they define culture to begin with. So it's a very broad concept, but really by relying on reflective exercises to teach people to think critically about things rather than relying on general assumptions or stereotypes is really an important thing to embed in a training. I hope that addresses these two related important questions as well.
There are some approaches too that I think that there have been out there in terms of how to teach the, especially healthcare professionals, some aspects of this. You know, one is the open-ended sort of questions, right? And making sure that people sort of have the open-ended strategies. But another is one that's promoted by the American Balance organization, American Balance Society, actually. And those are Ballant groups. Ballant groups were created by a psychologist, Michael Ballant, back after World War II, and which these were reflective exercises that are facilitated by individuals who kind of keep a safe space to allow providers to actually reflect upon interactions that they may be having with patients, especially ones that they are feeling are challenging or they're haunting in some sort of way, and then allow the group to, in a more imaginative way, kind of try to imagine what might be the contextual elements that may be related to both the provider and the patient, and then the relationship that's at hand.
Yeah, and Megan, and really again to further expand this question, is really, it's also about being mindful of language. I think language is where that's the tricky part, you know. So we also teach our students to think about the language or the linguistic choices that they make every day. How are you saying things really? How, and the tone and the words, because there is the thing about language, there's multiple ways to say the same thing, right? You can say how are you, you can say what's up, you can say what's going on, you can, and each one of them has interactional implications. And even I think Dr. Strang mentioned this earlier, also how you frame questions. You might ask a question to a patient about, are you safe at home? And you might get an answer. And you might ask them that same question in a different way, and you might get more information as well. So how we compose language and there's a lot of things that we take for granted when we're using language, and that's just the nature of language. How we, you know, if you look at how we close conversations, this is something they have done some work in 2009. How doctors close conversations with patients is also very important. Are we allowing people in an environment to expand more? Who gets to close? It's also a language and power question too, right? So those are, so really being mindful of how we're using language is critical as well. Yeah.
That's a great point. So I know we have just a few minutes left for today's session, so I think this will be our last question. This question comes from Emma in the chat. The question is, how do you advise providers to navigate respect for culture while also addressing cultural health practices like FGM, I believe female genital mutilation, or anti-vaccination beliefs? It seems like a delicate balance.
It's a very it's a big question. Yes, I mean, I support involving as many participants as possible in the conversation. I have been part of conversations locally that involved end-of-life discourse. And so obviously there is a religion aspect to it. And the imam was involved with the family as well. I think it's important to be as open to involving community members that a particular family have trust in, going back again to the question of trust. So we have to make sure, but we have to be respectful. We have to acknowledge those things as well. Culture is important. And so one of the videos that I shared with our students, Mohammed Kuchi, the Kuchi, it's an example of a cross-cultural, cross-linguistic encounter. Mohammed Kuchi, the patient in the film, refused chemotherapy because the way chemotherapy was broken down to the patient, it meant to the patient that the patient was going to be carrying a pump, which would then interfere with his blush. And again, it's okay if it does, but then again, nobody's in a position to question another person's eligibility. But it really came down to the very beginning. The translator didn't actually, in fact, translate very well what chemotherapy involved. They just put a technical term out there and left it with the patient to make sense of it. And the patient concluded that it's going to interfere with his ablage. But one of the things that I liked in that film is that the physician at one point says, at one point the patient said, our day has been chosen for us. Is a pious Muslim. And I really liked the physician's answer. It was such a culturally and linguistically competent one, saying, it is my job as your doctor to help you feel better until that day comes. And I thought it was an accident whether the provider believes in a day of judgment or our days have been chosen for us, but at least the provider was able to acknowledge that. And that's sort of very engaging way to involve the patient in their care. And yeah.
That's a
I don't know if,
fantastic
yeah,
example. I
yeah.
think the how we can kind of tread that delicate balance. We're seeing a lot of different personal beliefs that may be culturally related, may be politically related, may be housed within different sort of belief systems that might have different significance and yet not necessarily be compatible with scientific knowledge and medical facts. And so I think as a healthcare provider, one of the things that I tend to fall back on is exactly sort of what Sudi's example demonstrated, which is trying to find sort of the mutual vision, the mutual objective. We both want you to have the healthiest pregnancy there is. I want you to have the healthiest children as possible. And so it is my job to provide you with the medical facts and scientific evidence that is going to allow you to have that.
Yeah.
And in some cases, that's going to run counter to certain beliefs. And I respect your beliefs, but it is really my job to make sure that you stay safe. And so that's why I'm providing you with this information.
Yeah. Yeah. And again, to keep in mind, I bring back this slide again, these things again, sometimes you don't really know 100% whether certain things are cultural or religious or having just to do with literacy. So we really have to keep in mind. And the thing about culture as broad, as ambiguous and complex is that these cultural variables work together. And it's very hard to dissect which one is of these are really prompting a certain response by somebody. So
there are some strategies that the field of motivational interviewing can sometimes be borrowed to use, in terms of, again, that task, which is tell me more about your beliefs or tell me what you think, tell me what you're wanting. And then, how are we going to make that happen when there are these two things there? But also, especially with regard to certain things that might generate a lot of ambivalence, let's say like the female genital mutilation. One of the things that I'd want to ask is, how do you personally feel?
That's right.
About this? And what are the things that you're concerned about, and what are the things that you want? So.
Great, thank you so much. On that note, I think that we are about at time. So on behalf of the entire Liftoff PGH team, I would like to thank Dr. Sudi and Dr. Chang for joining us for a really great and engaging conversation today. And thank you also to the Humanities and Health Initiative at Pitt for being such wonderful partners. As Sudi said, we've been collaborating over the past several months. So it's really excited to see the partnership continue through this session. Thank you everybody for joining us today. That is the last session today for Liftoff PGH, but we have another really jam-packed day tomorrow. So we hope to see you all back. At noon, we have a pre-recorded mindfulness yoga session led by Venture Outdoors. If you miss it, it will be available after that time as well. So feel free to watch that at any point you are available. At 1 p.m., we are having a lunchtime conversation hosted by local journalist Natalie Bencivenga, who is going to talk about how to find a seat at the table as a young professional when you feel like you're being excluded from certain spaces or certain conversations. So that'll be really focused on advocacy, strategies for young professionals. At 2 p.m., we have a session on demystifying buzzwords in healthcare. So if you've ever wanted to learn more about FHIR, HL7, natural language processing, any of those buzzwords in the health and innovation space, we hope you'll join us for that. And then at 4 p.m. tomorrow, the Center for Women's Entrepreneurship at Chatham University will be hosting a networking session focused on the role of women in health innovation. So another really jam-packed day tomorrow. Thank you everybody again for joining us, and thank you to our two panelists. We hope to see you again tomorrow.
Thank you. Thank you,
Bye-bye.
Megan.
Thank you.
Thank you. Thank you.